So, telehealth service design and integration, we were asked to talk from the point of view of a large business. What are the challenges of dealing with clinical and technical integration with service providers and providing services to commissioners. And I think we probably fall into the realm of a large company, as we are 50% owned by Intel and 50% by GE Healthcare. Our organisation, Care Innovations, was spun out as a joint venture about 18 months ago. Intel and GE were both working on independent living, disease management technologies, telehealth, telecare, and decided to get together, work on it together, and like I say, form Care Innovations to accelerate the pace of the technology development and really enable us as an organisation get the products to market quicker than we could if we were within one of the larger parents. I worked in GE for 10 years before Care Innovations was formed, and I think I've seen more iterations of our current product in 18 months in response to customer feedback than I maybe did in the best part of 5 or 6 years working in one specific area of GE Healthcare. So I think we've made the right decision definitely to spin the joint venture out and to focus in on technology development in a very niche area at the moment. Even though we're a large company with two big parents, we're not averse to partnering. In fact, partnering is really the core of what I do in my business on a day-to-day basis. You can see the examples here on the board of the sort of companies we work with. We're still very much involved with our parents, but also other multinational organisations and local service providers. And hopefully you'll see as the talk progresses that all of these partners are absolutely essential to deliver a full managed service to the customer. Now that doesn't mean these are the only partners, and of course we recognise that there are public sector organisations which work in partnership with us as well. But nevertheless, I think some of these delivery partners can offer some key value in delivering the whole service. So when a service is initially being considered and created, what should we bear in mind? Well, obviously we have to look at the overall service, the scope of it, where technology fits into that, quality and cost implications, and what are the commercial processes that are going to actually bring this service into being. Of course, the mix of services will vary according to local requirements. Affordability a key issue. Clinical engagement absolutely vital. We've seen so many projects which have not progressed from a very early stage or don't move to the next stage if the clinicians aren't properly consulted and engaged throughout the whole process. The requirements of the patient is very important when you're looking at the platforms that you're going to use to deliver the service on. I just caught the tail end of this last gentleman's presentation, but I couldn't agree more with the last comment he made, that having the right platform for your patients to engage with them to make the service more efficient is absolutely crucial. While this isn't a sales pitch for Care Innovations in particular, I think we're wholly in agreement that that's the way we want to develop our portfolio of products. We don't want to be limited or constrained by the hardware choices that we make on behalf of patients, and we certainly don't want to be getting into any bespoke or proprietary systems of integration. And also different forms of contracting and putting your telehealth, telecare, telecoaching service together. It could be wholly public if you want to commission the technical service yourself and run the clinical service with the technical service as a tool on top. It could be wholly private. You can outsource completely to a private provider as a commissioner and just let them run the whole shebang and let them subcontract all the various elements. It could be a mix, and you could have one organisation, or, as I think will probably happen, a consortium. As I said before, we don't see one company, looking back at our list of partners before, we don't see one company there could offer absolutely everything to satisfy a local population, a commissioner, or even a provider organisation. So we think the consortium approach is probably the one that's going to prevail in the end with a lead partner. Okay, so the commissioned service, what should that look like? Should you, just take your existing clinical team, and dump a load of technology on top of them, let them get on with it, give them a bit of training, and expect them to get on with it and use it efficiently? Or should you embed the technology into a new service design, new care pathway as you're designing it? I think it's pretty obvious what my opinion is on that. I think it should be a natural part of what you're doing as you design a service, that technology should be considered an essential tool. It shouldn't feel like you've just stuck it onto the end. You should absolutely consider all the technical implications as you're designing your clinical service. So what are you going to commission? Are you going to commission from a regional point of view or from a CCG point of view? Are you going to set up your own technology based service that the clinical service providers can call on? Has the advantage of all systems being common, being able to talk to one another if you're sticking with one or a couple of approved technology providers and you're able to manage it, but does limit the choice of service providers as to the tools they can use to make their own service more efficient, run their own operation independently. And those clinical service delivery partners may have their own technical partner that they're going out to provide that outsourced service. But I think that whichever model you prefer and decide to go with, you're going to need to consider some or all of the points that we're going to address on the following slides. And of course it does depend on the ambition of the commissioning body. Do they want to take responsibility centrally, or do they want to pass that off as part of the clinical service? So what we have on the next half dozen or so slides is an outline model of what a managed service could look like, where our technology could fit into that. I've tried to keep it generic and remove the care innovation specific elements. And I think absolutely crucial is, as I've mentioned, making sure you get the strategic planning phase of your program right, even before you consider which technology you're going to go with, and how you're going to deploy that to patients. You know, what service do you want in place to satisfy the needs of your patients? How are you going to transform your business? How are you going to manage the hugely disruptive change process that introducing new technology is going to create? How can you support risk stratification? How are you going to select the patients that are required, and how are you going to determine which patients require which level of technology? I think you can probably all agree that there's just not one solution for a single set of patients. You're going to have a range, a spectrum of patients with a range of needs. You should really have a range of technologies and services in place to meet those needs, ranging all the way from a simple text service, maybe a support and phone call, even before that online self-help modules, something that's provided free of charge, all the way through to more expensive, higher functionality, more traditional telehealth, remote patient monitoring systems that are monitored on a regular basis, where there's a call centre support and backup, and we've got clinical response as well. So I think certainly in Care Innovations we recognise that we should be providing technology that support patients and clinicians at each stage, but I don't see any one company who's there yet, which is probably why in the short term the consortium or the framework approach is one that's going to prevail. At the end of the list there, project design and deployment strategy. I think this is what we've seen as hindering the success of some projects so far in the telehealth world. If you look at the reasons why some of these projects fail, or even fail to scale after an initial pilot, it's probably due down to poor project management and service design, and really not having the right deployment strategy, being over ambitious and not engaging with clinicians and patients. Clinical consultation as part of a service, certainly in the setup phase, is absolutely crucial. Running workshops to make service users aware that this service exists, to aid recruitment, which has been a huge barrier to scaling in this industry at the moment. Getting the clinicians on board so they will actually be part of the referral process. You need referrals of patients to actually feed into the system before you can start rolling it out. We actually offer a new service setup advisory service where we talk about our previous experience of deployments all across the world to to help advise customers on how to structure this properly. And we also, and I know this is a separate service you can take, we also create clinical protocols, and they are validated. It's not just me and my colleagues sat in a room making this up from scratch what we think is best for patients. We actually engage with proper clinical teams and go through the validated process to make sure it meets with peer-reviewed recommendations and research. We can also help with bespoke protocol development, and this is something you should consider for tailoring the systems to each patient's particular use. And then how you're going to create the content, how you're going to create the individual videos that you want to present to your patients, the news items, the research papers, and is that third-party content already there that you can tap into, and how do you integrate that into your telehealth solution? Program administration is actually one of the areas that we, I think, didn't see as being crucial when we first started this process. Maybe a bit naive really, but actually is one of the most crucial elements in this, making sure that you have the back-end office processes in place to make your telehealth, telecare program run efficiently. Who's going to register the patient, who's going to set up the protocols, who's going to create the evidence to support the ongoing use of this. It's probably not going to be the nurses, it's probably not going to be the technical team, so you've got to have a robust business process in place to generate constant evidence to support your ongoing use of the program. Technical deployment, obviously tightly controlled by various standards, and this must constitute delivery, installation, patient training at a minimum. There's great efficiencies to be made by installation and training being done during the same visit, whether that's a clinical person or a technical training session is up for debate, and we have customers who handle that in different ways. But the management of not just delivery and supply of the product, but also of the connectivity and communication is extremely important. We've gone into sites before where customers insist that we can do the telecoms ourselves. We've got our own broadband provider within the trust. You just provide us with the boxes. Of course, when it goes wrong, the buck gets passed around. Nobody wants to take responsibility. So we've pretty much started insisting that if customers take equipment from us, unless they can demonstrate they've got robust service and maintenance procedures in place with their broadband provider, that we'll provide the connectivity. It doesn't work out any more expensive, it just means that when a customer has a problem, they've got one person to come to and not a wide range of people to go and berate. And at the bottom there, very important, taking advantage of mobile technologies. We have moved our platform onto a tablet PC, which is in the over here. You don't need to pay too much attention to it. It's a generic off-the-shelf tablet PC, but these are the sort of hardware devices, if people don't have their own, that we should be looking to supply. Wi-Fi enabled, 3G, hopefully 4G when that gets up and running, and it means that we have reliable connectivity in a given area, and we're not reliant on a telephone line, which surprisingly a number of people don't have when you go and try and install. And if broadband for a temporary installation is very expensive and very limiting, so we're finding Wi-Fi and 3G is probably the most efficient way for us to work with our deployments at the moment. The equipment supply I mentioned, again, very important. We have a range of hardware available. We don't want anything bespoke, we don't want anything tethered to the wall. We want a range of devices which are suitable for the patient and their needs. So with having a software-only solution, you can go for the small, sleek tablet, you can go for something that's a little smaller, or you can go for a big 25-inch all-in-one PC for someone who's got low visual acuity, maybe that's got rheumatoid arthritis, got dexterity problems. But the hardware shouldn't limit somebody's acceptance onto the program, or their ability to use the hardware, should I say. The software-only approach certainly is going to drive costs down, and that's a direction of travel that we are moving in at the moment. Having a range of peripherals which connect using wireless technology and have the backup of being wired, and also having patients being able to use their own peripherals if that's desired. And again, supply of the telecoms equipment, if that can be controlled and considered, that's less problems for everyone. The actual telehealth platform itself, should be flexible enough to scale, to be personalised, and to accept third-party information as well as the system information you're generating yourself. Obviously most systems will have a triage-based system embedded in there where you manage by exception, but also to be able to manage patients in terms of care coordination, pass patients between healthcare professionals, to exchange data between different systems. Very important that the telehealth system is flexible enough and open enough. When I've shown you, we've certainly progressed to open standards by using off-the-shelf hardware. We use standard web service protocols to build our security, standard operating systems. We use Windows. Nothing bespoke really to try and limit adoption of the technology. And data integration, having a range of integration options, being able to integrate with patient health records, looking at GP records as well, being able to produce reports on demand, it is all absolutely essential. Probably this element of the service is, I think, going to become even more valuable in the future as we move towards more generic devices, more generic platforms. It's how you use the data in the background that's going to be absolutely key. And clinical monitoring and response, I've spoken to a couple of colleagues this morning. Actually, we don't have our own monitoring and response centre, but speaking to a couple of potential partners this morning, it's really interesting the position that these sorts of organisations could hold within the provider landscape. They are starting to bridge the gap between health and social care at the moment, but I think having a robust clinical triage, clinical monitoring capability within that contact centre is absolutely crucial to be able to filter out the patients who don't need that face-to-face interaction, who don't need the intervention from the clinical providers on the ground. We've seen some evidence from other partners that suggests that's true, that you can make significant efficiency savings by triaging not only with the system but with a clinical contact centre before a home response is initiated. So just a couple of other points to consider. The financial model that would support the deployment of such a service. I think it's pretty clear that there's no capital to be spent at the moment. When you listen to the ministers and when you listen to Steve Johnson, absolutely crystal clear that we are not going to have any capital expenditure to fund expensive pieces of hardware. So we're looking at a revenue model, and can we build an element of risk sharing or saving share into that to try and reduce the risk to the customer and try and reduce the burden on them to prove return on investment in, typically now is a 12-month period. I'm speaking to customers and there's really nobody who's saying, oh yes, don't worry, we've got 2 years to prove this is cost effective. Everybody's saying, yeah, and can you prove it in the next 9 months, so I'll get my budget approved for next year to keep it going. Well, that's probably not very helpful or practical. So we, as an industry, have to come up with a viable financial model which helps our customers deploy this at scale, but also, helps us retain our interest as a commercial organisation, and keep us here for the long term. We're not in this, just to sell a load of kit, dump it, and then leave. So some of the points, as we've been discussing in the 3 Million Lives team, some of the points we're sort of discussing at the moment are, if we can look at a patient volume commitment, it makes the business for us a lot more viable. It means that we can commit to support hardware deployment, that we can support a revenue-based model, and that the fact that you need to prove return on investment within a short window doesn't become so crucial. But then there's another option of a long-term contract, which means the costs can be reduced even further. But this requires a long-term vision and plan, which at the moment, from the customers I've been speaking to, just isn't quite there yet. Having standard and variable charges for service design, for service use, and fees based on per patient per day and on service level is pretty standard across the industry at the moment. So I think there's a way we can work a financial model that fits with the commissioner, that fits with the service provider, and that also gives us the ability to help scale this up to the levels it needs to be, which, to be honest, is in the tens of thousands for a region. How is the service procured? Well, if it's a purely technical service, you can go through the old buying solutions, newly named government procurement service has just been renewed for another 12 months. There's another 12-month option from next August, although I believe there's a procurement consultation by the government happening at the moment, so I wouldn't anticipate that'll be renewed again. And through that contract it's split into different lots, and you can procure telehealth, telecare equipment and services, telecoaching and managed services. This means you don't have to go out to the ODU process. Yeah, it's not been widely used, but certainly has the potential over the next 12 months with 3 million lives and Dallas coming to fruition to be used a lot more widely.